Sorry for losing concentration here, guys. Okay, so let's continue. What about Kussmaul breathing? Hmm?
No worries. Let's jump to Kussmaul breathing. Kussmaul breathing is fast, deep, labored breathing to compensate for metabolic acidosis, low blood pH, e.g., from diabetes or kidney failure. High CO2 or acid triggers brain chemoreceptors, speeding up breathing to blow off CO2, raising pH. Unlike VQ mismatch, it's not a lung issue, but a response to blood chemistry. Example, diabetic ketoacidosis causes it. Clear? Want more on causes or how it differs from other breathing patterns?
I want to ask you about how anemias affect the respiratory system.
Anemias reduce red blood cells or hemoglobin, cutting oxygen carrying capacity. Lungs compensate by increasing respiratory rate or depth to boost oxygen intake, raising PaO2 to saturate remaining hemoglobin. Heart rate also rises to deliver oxygen faster. Symptoms: shortness of breath, fatigue. Severe anemia can cause hypoxemia, despite normal lungs, mimicking respiratory issues. No direct lung damage, but VQ mismatch or high AA gradient can worsen if lung disease coexists. Clear? Want specific anemia types?
Yes.
Common anemias impacting respiration. Iron deficiency anemia. Low hemoglobin from iron lack. Less oxygen carried, so breathing and heart rate increase to compensate. Shortness of breath common. Sickle cell anemia. Misshaped red cells block vessels, reducing oxygen delivery. Lungs hyperventilate. Acute chest syndrome. Lung vessel blockage. Mimics pneumonia, raising AA gradient. Thalassemia. Defective hemoglobin production. Similar to iron deficiency, with faster breathing to offset low oxygen capacity. All trigger compensating faster, deeper breathing. No lung damage, but worsen if VQ mismatch exists. Clear? Want more on one type?
No, that's good. Okay. Can we talk a bit about the development of the lungs? So, for instance, talk about the endodermal bud, the gut tube, trachea or esophageal septum.
All right. Lung development in utero, focusing on key structures. Embryonic stage, weeks 4-7. Lung buds form from the foregut. Gut tube, a ventral outpouching. Endodermal bud splits into two bronchial buds, starting trachea and main bronchi. Tracheoesophageal septum divides foregut into trachea, ventral, and esophagus, dorsal. Defects cause tracheoesophageal fistula. Pseudoglandular stage, week 7-16. Bronchial buds branch into smaller airways, forming bronchial tree. Canalicular stage, week 16-26. Airway branching continues, primitive alveoli and capillaries form. Surfactant production starts. Saccular alveolar stages, week 26 birth. Alveoli mature, increase in number. Surfactant ensures lung expansion post-birth. Endothelium, capillary lining, develops alongside alveolia, enabling gas exchange by birth. Structure, early buds dictate airway layout. Septum ensures separate airway digestive paths. Clear? Want more on defects or stages?
I want to ask you about the cephalic end and the caudal end, and then what's going on. We have suddenly now the lung bud splitting to the bronchial buds, and this is such an abstract process to me.
I hear you. Lung development is wild and abstract. But let's make it clear, focusing on cephalous caudal ends and the lung bud split. Early embryo, week 4. The foregut, part of the gut tube, has a cephalous end. Head side, future mouth, pharynx, and caudal end, tail side, future stomach, intestines. Lung development starts mid-foregut. A single lung bud, endodermal outpouch forms ventrally from the foregut, triggered by signaling like FGF from mesoderm. By week 5, this bud splits into two bronchial buds, left and right, the start of the main bronchi. The tracheoesophagalius septum forms simultaneously, separating the trachea from lung bud from the esophagus, foregut's dorsal part. Cephalous end of the bud becomes the trachea, caudal end branches into bronchial buds, which keep dividing into the bronchial tree. It's abstract, but think of the lung bud like a sprouting plant. One stalk, bud, splits into two branches, bronchial buds, to form the lung framework. Clearer? Want a
Yeah.
visual analogy
And
or
we
more
also
on
have
why?
cervical, superior. We have diaphragmatic pleura, inferior. We have mediastinal, which is like medial. We have costal, which is kind of anterior.
You're talking about the pleural surfaces and orientations in the thoracic cavity, likely tying back to lung anatomy. Let's clarify. The pleura membrane around lungs has regions named by their position. Cervical pleura, superior, extends above ribs into neck, near lung apex. Diaphragmatic pleura, inferior, lines diaphragm, where lungs rest. Mediastinal pleura, medial, faces mediastinum, heart, trachea. Costal pleura, lateral and interior, lines ribs and chest wall. These describe the parietal pleura's contact points around each lung in the pulmonary cavities. Structure fits function, protects lungs, allows smooth movement during breathing. Not directly tied to lung bud development, but defines lung positioning post-formation. Clear? Want to link this to development or pleural function?
No, but let's talk a bit about the nerve supply, like the phrenic nerve and intercostal nerves.
All right. Nerve supply to the thoracic cavity, focusing on phrenic and intercostal nerves. Phrenic nerve, C3-C5, innervates the diaphragm, driving breathing. Motor fibers contract diaphragm for inhalation. Sensory fibers detect stretch or pain. Damage causes breathing issues. Intercostal nerves, T1, T11, supply intercostal muscles between ribs for chest wall movement during breathing. Sensory fibers cover chest wall pain sensation. Phrenic is key for diaphragm, inferior pleura contact. Intercostals support rib cage, costal pleura. Clear? Want more on nerve roles or issues?
That's good. What about the visceral pleura? What nerve supplies?
Visceral pleura, covering the lungs directly, gets its nerve supply from the autonomic nervous system, mainly vagus nerve, parasympathetic, and sympathetic trunk. Unlike parietal pleura, it lacks somatic nerves, like phrenic or intercostal, so it's insensitive to pain, but responds to stretch or autonomic signals.
And what
aiding
is
lung-
the pulmonary plexus?
The pulmonary plexus is a network of autonomic nerves, sympathetic and parasympathetic, around the lung root, near the bronchi and pulmonary vessels. Sympathetic fibers from sympathetic trunk cause bronchodilation and vasoconstriction. Parasympathetic fibers from vagus nerve cause bronchoconstriction and secretion. It regulates airway diameter, blood flow, and mucus production in lungs, including visceral pleural reflexes. Clear? Want more on its role in breathing?
Let's talk a bit about the pleural cavity. So the space between the two layers of pleura. It has serous fluid. This tension helps us to do what exactly?
The pleural cavity between visceral and parietal pleura holds a thin layer of serous fluid. This fluid reduces friction, letting lungs slide smoothly during breathing. It also creates negative pressure, slight vacuum, keeping lungs expanded by coupling them to the chest wall. This tension aids inhalation and prevents lung collapse. Clear? Want more on fluid issues like effusion?
Well, that's good. Okay, let's talk a bit about pleural cavity recesses. So we have a costomediastinal, a costodiaphragmatic. What is this?
Pleural cavity recesses are potential spaces in the pleural cavity where parietal pleural layers meet with no lung tissue normally. Costomediastinal recess, anterior, where costal pleura meets mediastinal pleura, near the sternum. Costodiaphragmatic recess, inferior, where costal pleura meets diaphragmatic pleura, deepest during exhalation. They allow lung expansion during deep breaths and can collect fluid in conditions like effusion. Clear? Want more on clinical issues?
I don't get what it is.
All right, simpler. Pleural recesses are small gaps in the pleural cavity where the parietal pleura folds touch, no lung inside. Costomediastinal recess is up front, near the heart and sternum. Costodiaphragmatic recess is low, by the diaphragm and ribs. They're like extra space for lungs to expand when you breathe deep. Clear? Need an analogy?
Okay, and the right lung has 3 lobes, right?
Not quite. The rib cage itself doesn't have lobes.
No, I said the right lung.
My bad. Got you. The right lung has 3 lobes, upper, middle, and lower, divided by oblique and horizontal fissures. The left lung has 2 lobes, upper, lower, due to heart space. Lobes increase surface area for gas exchange.
Superior, middle, inferior, yeah. And what's the lingula and the cardiac notch?
Right lung has 3 lobes, superior, upper, middle, inferior, lower, not medial. Left lung has 2, superior, inferior. Lingula, a tongue-like part of the left superior lobe, sticking out, like the right's middle lobe, but smaller. Cardiac notch, a dent in the left.
Yeah, okay, lingula is his tongue, and then cardiac notch, what is that?
Left superior lobe where the lingula, tongue-like flap on the left lung superior lobe, similar to the right lung's middle lobe. Cardiac notch, indentation on the left lung superior lobe where the heart nestles, reducing left lung size. Both shape lungs to fit chest cavity and heart. Clear? Want more on their role?
I want more on this, yeah. I mean, I still don't understand the cardiac notch.
The cardiac notch is a curve-shaped dent on the medial side of the left lung superior lobe. It's where the heart bulges into the left thoracic cavity, pushing against the lung. This notch makes the left lung slightly smaller and asymmetrical compared to the right, accommodating the heart's position. It's just a structural adaptation, no direct function, but ensures space for the heart while maximizing lung volume. Clear? Want a visual or more on lung?
No, that's okay. And let's talk a bit about the blood supply of the lungs. So, you have bronchial arteries supplying oxygen to the lung and visceral pleura. We have the descending aorta and the intercostal arteries. And we have bronchial veins. Explain us what's going on here.
Lung blood supply. Bronchial arteries, from descending aorta or intercostal arteries, deliver oxygenated blood to lung tissue, bronchi, and visceral pleura, supporting their metabolism. Bronchial veins drain deoxygenated blood from these structures, partly to azygous veins, partly mixing with pulmonary veins. Pulmonary arteries, from right heart, carry deoxygenated blood to alveoli for gas exchange. Pulmonary veins return oxygenated blood to left heart. Bronchial system feeds lung structure. Pulmonary system handles gas exchange. Clear? Want more on dual supply issues?
So intercostal arteries and descending aorta supply oxygen to the bronchial arteries?
Yes, exactly. Bronchial arteries, which supply oxygenated blood to lung tissue, bronchi, and visceral pleura, typically branch off the descending aorta, thoracic portion, or, less commonly, intercostal arteries. These feed the lung's structural needs, not gas exchange, which is handled by pulmonary arteries. Clear? Want more on how they connect?
Okay, yeah, I mean, it's a bit weird that they get it from different places.
Yeah, it seems odd, but it's efficient. Bronchial arteries usually come from the descending aorta because it's a major, high pressure source of oxygenated blood, perfect for feeding lung tissue, bronchi, and visceral pleura. Intercostal arteries, which supply chest wall, can chip in for some bronchial branches in rare cases, giving backup routes. This dual origin ensures the lungs get steady oxygen for their own needs, separate from the pulmonary artery's job, gas exchange. Clear? Want more on why this split matters?
Um, I want to ask you about alveolar ducts. So they're elongated airways and they open into alveoli.
Yep, alveolar ducts are thin, elongated airways in the lungs that connect respiratory bronchioles to alveoli. They're lined with tiny air sacs, alveoli, where gas exchange happens. Duct walls have smooth muscle and elastic fibers, letting them expand during inhalation. They open into alveolar sacs or directly into alveoli, maximizing surface area for oxygen CO2 swap. Part of the respiratory zone, they're key for efficient gas transfer. Clear? Want more on their role or
And what are
structure?
type 1 and type 2 pneumocytes?
Type 1 pneumocytes, flat, thin cells covering 95% of alveolar surface, enable gas exchange, oxygen, CO2, due to their minimal thickness. Type 2 pneumocytes, cuboidal, 5% of surface, produce surfactant, reduces alveolar surface tension, prevents collapse, and can divide to replace damaged type 1 cells. Both are in alveolar walls, critical for lung function. Clear?
I don't get
Want
what
more
the,
on
to be honest,
surfactant or repair?
yeah, tell me again, what is type 1 and type 2 pneumocytes?
No problem. Type 1 pneumocytes, super thin, flat cells, making up most of the alveolar wall, letting oxygen and CO2 pass easily for gas exchange. Type 2 pneumocytes, thicker, boxy cells, fewer in number, make surfactant to keep alveoli from collapsing and can turn into type 1 cells to repair damage.
I
Clear?
don't get
Need a
what
simpler
their
breakdown?
function is and how the name relates to the function. Huh?
All right, let's break it down. Type 1 pneumocytes, named type 1 because they're the primary, most common alveolar cell. Function: thin, flat structure forms a wide, permeable surface for easy gas exchange. Oxygen into blood, CO2 out, like a thin window for air to pass. Type 2 pneumocytes, called type 2 as their secondary, less common. Function: make surfactant, a soapy liquid, to lower alveolar tension, preventing collapse, and
I
act
don't
as
get
step.
it. Can you explain it really simply?
Okay, super simple. Type 1 pneumocytes are thin cells in alveoli that let oxygen and CO2 flow easily into and out of blood, like a paper-thin filter. Type 2 pneumocytes make a soapy liquid, surfactant, to keep alveoli open and can grow into type 1 cells to fix damage, like repair crews. Names just show type 1 is main for gas, type 2 for support. Clear? Want an analogy?
I'll be honest, dude. I still don't get it.
All right, no stress. Let's try an analogy. Imagine alveoli as tiny balloons. Type 1 pneumocytes are the super thin balloon walls, letting air, oxygen, slip through to blood easily. Type 2 pneumocytes are like workers inside, spraying soap, surfactant to keep balloons from sticking shut and patching holes by making new, thin walls. Type 1, exact, thin for breathing. Type 2, soap and repair. Clear? Want to try a question to test it?
Okay, that kind of makes more sense, yeah. Okay, let me ask you something different now. So